Thank you for inviting me to give this lecture. Today I will be talking more on the central aspects of the peripheral nerve injuries and looking at some of the advances that has occurred and how that will impact you as a peripheral nerve surgeon. Today I will look at the various aspects of how the injuries to the nerve affect the individual. We will look at the framework and how motor action requires evolution and the ideomotor theories. We will look at the role of the brain and plasticity in nerve injuries and its rehabilitation. And we look at our peripheral strategies that we are focused on in an attempt to bring the patient back to his pre-injury status. We also will look at neuromuscular rehabilitation and how the recent advances has impacted rehabilitation, and a quick look at the future of nerve surgery. For those who would like to have a more structured, basic lecture on the nerve injuries and their management, you could go to this QR code and look at module number 6. The peripheral nerves are the organs through which we interact with our universe. We obtain sensation from the situations around our universe, from which we then decide on human volition, which is to perform a particular task. This is dependent on what is known as the Ideomotor framework, through which we then conduct various motor tasks. It has got a concept of generativity, which is the capacity to trigger action, and the subjectivity is the conscious experience associated with initiating voluntary actions, and teleology, which is the goal-directed quality of voluntary actions. And in this Ideomotor task execution, it can be seen here that the mental representation of the task that we want to perform is started within the brain, and from which there is an activation of motor plans, which are the neural synapses that are responsible for a particular motor action. And this is then executed following the idea of creating a motor task. The motor execution then produces various sensory feedback, kinesthetic cues through which the reinforcement is obtained, and finally an evaluation is performed on the outcome of that motor task. So these are the various steps involved in ideomotor creation. The seat of motor action obviously is in the brain, is in area 4 and area 6 of the primary motor cortex, which is in the precentral gyrus. There is a supplementary motor area, which is the area 6, where the planning and execution of complex movements are occurring. So here is where the ideomotor originates for the ideomotor steps for performing a motor task. There's also an area in the lower portion of the parietal lobe known as the mirror neuron system. This is important for imitation, and this is later we will see how this can be used in rehabilitation. And the other aspect is there is a concept of a command center. The command center is a single neuron that will fire in the brain to create complex motor tasks. And it's important to understand this for the phenomena of plasticity. And so this is why we are able to produce complex tasks rapidly. And so therefore, when we try to analyze a simple motor task as performing a grasp action, which is to protract the arm in space, to extend the elbow and grasp an object with the hand, this complex task is done rapidly because of that command motor neuron, which has learned the various aspects to produce that action. And so knowing these pathways is important for us to understand the impact of peripheral nerve injuries. Remember, there is the homunculus in the precentral gyrus of the brain, which represents various parts of the body. Similarly, there are homunculus in the spinal cord, in the corticospinal tract, that is responsible for motor action. And here we see when we have a nerve damage, there is significant connection between our peripheral nervous system to that of the central nervous system, and immediately there are changes that occurs. There is maladaptive neuroplasticity, which is negative towards the outcome. There is a process of central compensation that occurs, and it's been shown through closed loop vagus nerve stimulation that this can reduce the amount of negative plasticity occurring in the brain, and it reorganizes the synapses to provide alternative pathways, and this has been shown to improve sensory motor recovery and enhances the central plasticity towards the final outcome of rehabilitation after a nerve injury. So these are important findings that one must understand as we practice peripheral nerve surgery. So the moment there is a nerve injury in the periphery, there are significant changes that occur not only locally but also centrally, from a chemical level to a cellular level and towards neurological and electrical stimulation. And so there are many factors that are involved in the regeneration of a nerve, and so we must be very clear about the concepts of Wallerian degeneration, the role of the Schwann cells in the regenerative process. And so there are lots of factors that are involved to enhance and improve cellular and neuronal regeneration. So in this diagram, you can clearly see what happens in terms of a crush injury and a complete transaction of a nerve. And one of the challenges has been, even though we do nerve repairs, is the direction of the axonal regeneration towards the end target organ. And this has resulted in various techniques that we have now used to improve outcomes in peripheral nerve surgery. The role of the Schwann cells is significant both in plasticity and in the regeneration of the nerve. They provide the cellular energy that is required in the regenerative process to allow for the direction of the axons that are regenerating down to the appropriate tubes to reach the target organ of concern in that particular injury. The central role of the brain in nerve injury has been shown by Lundborg's seminal paper on plasticity of the brain. It is important for us to understand that a lot of things happen centrally, and our peripheral nerves are just a small portion of that complex synapses between neurons that go towards a particular perception of the environment to that of a motor task that needs to be performed. All these are dependent upon dendrites formation within the neurons and the synapses. Immediate changes occurs and alternative pathways are created. And Goran Lundborg talks about how the median nerve injury with the loss of sensation in the thumb and the index finger results in a black hole which then encroaches from the nearby homunculus, which is mainly the eye, and how those can produce changes during regeneration. Neuroplasticity is also about the concept of repeated and persistent stimulation over a synapse, and this is very important in the recovery following nerve injury, and this is known as Hebbian learning. This similar type of neural networks have been used in artificial intelligence, and we realize that as a result of nerve injury, there's significant changes that occurs in the central nervous system in the brain, with extensive rewiring through this dendrite formation and new synapses. And this is induced after a period of neuronal inactivity as a result of a peripheral nerve injury. So the role of promoting central plasticity is important in towards the rehabilitation and recovery after a peripheral nerve injury. And this has been shown through neuromuscular electrical stimulation and also enhancing plasticity through central network stimulation, like for example, vagus closed loop stimulation. Stimulation of the vagus results in stimulation of the brain, and this can then promote plasticity and alternative pathways to improve function. This can also be seen by stimulating the brain extracranially. It is important to realize that there are new neural pathways that occur following peripheral nerve injuries, and these are direct parietal connection to the spinal interneurons. The corticospinal tract has got lamination of fibers, and these are modulated by central fibers to help towards recovery, and it supplements the regeneration. Common injuries that are seen is digital nerve injuries, and there's been no evidence to show that repairing the digital nerve makes any outcome different, yet we continue to do so based on dogma. So, how do we reconstruct a nerve when you have a gap? Even a normal nerve following division due to the process of tensegrity results in a gap because it contracts. And the aim of nerve repair is tension-free coaptation. How do we achieve this? Is it through grafting? Is it through the use of conduits? And these are some of the recent strategies that have been applied. Some of the recent strategies has been the use of various materials to bridge the gap in terms of allografts and also conduits. Ideally, the material of choice would be an autograft, but the aspect of a donor defect must be considered. These challenges, and with the concept of Wallerian degeneration and motor end plate atrophy due to proximal nerve injuries, brought about the concept of nerve transfer. So nerve transfers have made a significant difference, and today it is part and parcel of the armamentarium of a peripheral nerve surgeon to ensure motor recovery occurs optimally by the use of early nerve transfers, and it can be end-to-end, end-to-side. The concept of babysitting has been proven in the animal. Now we move on to spasticity, upper motor neuron lesions affecting both upper limb and lower limbs. A lot of peripheral nerve surgeons have taken an interest in this area. Spasticity provides significant disability to individuals, and understanding the pathophysiology helps us in providing strategies in peripheral nervous system to help with ideomotor task in patients with post-stroke or in cerebral palsy. So spasticity is basically a reduction in the inhibition of the central fibers from the brain, resulting in an increased tone in peripherally, which is velocity dependent, and it results in a hyperexcitability of the stretch reflex. Co-contraction of the agonist and antagonist results in this rigidity in the peripheral muscles, which then, if neglected, progresses to contractures, and they account for about 30% of patients with stroke and traumatic brain injuries, and 80% of spinal cord injuries would have spasticity. So the impact of spasticity on the motor task is the inefficient utilization of energy, of external energy to produce the motor task. So we go back to the Ideomotor framework for a particular task. So the patient has an idea of wanting to perform a particular action, and because of the increase in the spasticity, is unable to perform it because of the energy that is dispensed. And one of the important aspects of the Ideomotor framework is the outcome that is obtained from the idea of performing a motor task. So when there is no goal that has been achieved, there is no reward, and the patients therefore do not perform the act and will look for compensation with the other limb. And so by reducing the spasticity, it encourages for individual to perform the task. And here again, the role of robotic rehabilitation with assistive techniques used with the use of robotic exoskeleton can help in the rehabilitation of the individuals. So this has resulted in the role of the peripheral nerve surgeon in the spasticity care pathway. And here is the algorithms that I use in our stroke hand clinic that we run, where we use various techniques. And in early cases, the role of neurectomy to help reduce spasticity is becoming more popular, and there is definitely a basis for this to improve the functions and rehabilitations of individuals who have had strokes or any form of spasticity. Next, we look at rehabilitation. So there are a lot of advances that has occurred in technology and various techniques for rehabilitation after nerve injuries. And it's very important to understand that there must be a careful documentation of the patient's narrative in terms of how they're coping with the biophysical impact of peripheral nerve injury. And it's also important to understand that this affects them psychologically and also in young individuals in terms of their earning capacity. And so unless we start to understand this and document this, it's very difficult to look at outcomes in peripheral nerve surgery. And one of the important aspects of the rehabilitation of patients with peripheral nerve injury is the role of the central component, which is the brain, in peripheral nerve rehabilitation. As we talk about the Ideomotor framework, where all action is goal-directed action, that we are trying to get the patient back towards this pre-injury state in achieving a motor task. So it is the understanding of the motor task in the brain system, and by watching and seeing the sensory input of the motor task either in a visualization in the brain or by direct observation, produces the necessary ideation to reproduce that movement. And this persistent and repeated efforts through mental practice helps in the neural pathways in the axonal regeneration to help the patient achieve that task. And this is the role of the mirror neuron systems, and which then can be used to help the patient rehabilitate after nerve surgery or reconstruction. So this is activated when the patient executes, observes, or anticipates and imagines that motor task. That is a crucial element, and this now have been incorporated into post nerve surgery rehabilitation program by physiotherapists, and this has helped to improve the outcomes. The other aspect is the kinesthetic imagery, again going back to the Ideomotor framework, where it is important to understand the sensory components that are involved in the execution of a motor task. So the rehabilitation framework has shown that if we use all these techniques, there are changes in the synapses in the centrally and also in the corticospinal tract, in the spinal cord, that produces new synapses and alternative pathways that are intensified to produce the necessary outcome that we want at the end of our rehabilitation. So this sort of techniques in neurorehabilitation needs to be understood, and these are not expensive techniques, doesn't require much technology, but the use of various training processes. So this simulation-based priming is one of the important aspects in neurorehabilitation, where the mental simulation, this is based on the fact that if we continue to think about that action through imagery and observation, and the sensory priming through kinesthetic cues, that means to imagine that movement with all the kinesthetic cues, brings about neuronal changes in the synapses, and that would help in the priming of that final motor task, not just chemically with pharmacological active compounds within the synaptic junctions, but also structurally with new synapses being created. The other aspect that has impacted neural rehabilitation is the role of robotics. So robotics has played a significant part. We have used some of the robotic techniques in our lower motor neuron lesion, and this can also work with upper motor neuron lesion. So they become a vehicle to translate the intensity of a rehabilitation program by measuring the patient's effort and providing assistive forces to create the goal, and therefore reinforce this to allow the patient to be motivated to continue to undergo rehabilitation. It provides excellent objective evaluation tools so as to be more structured in our evaluation, and it's a great enabler to help with the total rehabilitation. So how do you look at the future of peripheral nerve surgery? I think with the advancements in stem cell and genetic engineering, there will be significant impact on peripheral nerve regeneration through the use of various uh, materials, and the role of nanotechnology in the deliverance of specific chemicals and hormones at the level of the regeneration would make an impact. The role of 3D printing with scaffolds can also provide solutions for the use of conduits and gaps. Robotic surgery, in terms of helping in the surgery with the use of robots for microsurgery are already in place, but I think the role of robotics that will develop in the future would be in robotic neurorehabilitation with the use of specific robotic assistive device with AI and big data. The neural prosthetics, I think, will come more in play as we look forwards, with sensate hand playing a significant role, and targeted motor re-innovation's role in, and also the mapping of the stump to provide sensate prosthesis. As we move forward in minimally invasive surgery for neurectomies and nerve transfers, will come in with specific imaging techniques in identifying nerves, negating the use of extensive incisions. Artificial intelligence, augmented reality, and virtual reality will play a significant part in the rehabilitation process, especially as we have looked at the mirror neuron phenomena and the Ideomotor framework, and these will be very useful. As you can see, that collaborative care is going to be important, the role of the allied health professions and the patient role in the rehabilitation is going to be useful, and especially with technology, this will be possible with the use of various technological enhancements and wearable devices to help patients provide the data and to generate bespoke rehabilitative techniques that are specific for the patient. Thank you, and I look forward to your questions.